Good evening, everyone. Yeah, thank you everyone for coming in this wonderful weather day we have in February, where it is Heart Month and it's also usually a pretty tough weather month as well. For those people who traveled through the snow to get here, we appreciate you coming. And for those watching on web broadcasting, we welcome you as well. Unfortunately, Donna Duncan, the Sunnybrook board member who you introduced this evening, is unable to attend tonight. So in her place, I will welcome everyone. My name is Brad Strauss. I'm the chief of the Schulich Heart Program, and it's been my pleasure to be the moderator for these sessions for the last number of years. I have one more to go next year, so we look forward to having one more shot at this next year. So we have an excellent evening set of lectures planned for you, and they came, as usual, they cover a wide variety of topics, and we try and bring you some of the latest news in our annual cardiology focused talk. The lecture tonight is called An Evening Discussion on the Heart. We'll look at medications, transcatheter aortic valve implantations, also known as TAVI, as well as treating leg ulcers. I'll introduce the speakers, and I will give a few minutes, particularly after Dr. Radhakrishnan has to run out to a hockey game. He's playing for the Leafs tonight, and they need an extra body because of the weather, so he has to run down there. So if you have questions in the audience, maybe we'll take them after. We'll try, the two of us will stay behind and try and answer your questions. So thanks again for everyone attending. I really appreciate, on behalf of the Heart Program, the interest that's always shown by the community in health-related matters. It's an important month and it's an important disease. So our first speaker for the evening will be Claudia Bucci. Claudia is a pharmacist. She's a fantastic pharmacist who's worked with us for many years here. She's involved in numerous cardiovascular research projects, and certainly whenever I have a question, which is very frequently, I email her and she always comes back with the right answer and does it in a very quick way. So I'm always grateful that I have the opportunity to work with Claudia. Thank you, Claudia. Tonight she's going to talk about diabetes drugs for a healthy heart, and there's been a lot of change in that over the last couple of years, so I'm sure you'll find it interesting. So Claudia, please take the podium.
Thank you very much. It's a pleasure to be here tonight. I love talking to patients and sharing what I know about drugs. Specifically, cardiovascular drugs has been my focus for about 15 years or so now. And over the last couple of years, I've had to learn more details than ever about diabetes drugs too. And I'm going to tell you why in a second. Thank you for the warm welcome, Dr. Strauss. Over the next little while, I want to talk about how we can lower cardiovascular disease in patients with diabetes. And there is probably a handful of you in the audience right now that are managing both drugs for cardiovascular disease, but you also have diabetes. So you're managing insulin and other medications, oral medications such as metformin, etc. So I'm going to talk a little bit about that. I'm going to share with you the 2018 Canadian Diabetes Guidelines. And these guidelines really are a game changer in the world of diabetes, especially in patients who also have heart disease, and I'll tell you why. And lastly, I want to help you to understand the benefit of new classes of medications, specifically new medications for diabetes that actually lower cardiovascular risk. So this is new. And these therapies are quite novel. Diabetes is a growing epidemic. Today in Canada, there are over 11 million Canadians living with diabetes and pre-diabetes. And certainly there is no shortage of information and headlines out there about how the incidence of diabetes is on the rise. And this is an example of one that I pulled from, I think it was the World Health Organization, quoting how many millions of people in the world live with diabetes, and the risk of complications from diabetes and the risk of complications also from heart disease in patients with diabetes. Cardiovascular disease is the most common complication in patients with diabetes. The good news is that that risk of heart disease can be lowered using a combination of medications and lifestyle interventions. And those are often referred to as the ABCDEs for ease of remembering this acronym. These are the key things to know if you have heart disease and you also have diabetes. A stands for A1C, which is also known as hemoglobin A1C, which is a blood test that measures blood sugar control over a long period of time. And the optimal A1C for most patients is less than 7%. There are some cases where we aim a little bit higher, and some cases where we're more aggressive, but in general, for most of the population, it's less than 7%. Blood pressure control is very important in diabetics as well, and the target blood pressure is 130/80, which is more aggressive than patients who don't have diabetes, where the target is 140/90. Cholesterol is very important. Reaching an optimal LDL or bad or lousy cholesterol level of less than 2 millimoles per liter is the goal in patients with diabetes, or at least a 50% reduction in LDL cholesterol levels. D stands for drugs to protect the heart, and I'm going to get into those. E stands for exercise and healthy eating. S is for smoking cessation. So lifestyle interventions are just as important as drug therapy in reducing the risk of complications from diabetes. So A1C, I have a slide on it because I'm going to refer to it a little bit later on. A1C, which is often also called hemoglobin A1C, is that blood test that is not the blood sugar test. I know that many of you use your blood sugar levels to monitor your blood sugar control on a day-to-day basis, and that's very important. The A1C also has an important role. It's usually measured less frequently because it's very useful when we're deciding what changes to make to diabetes medications. So, for example, if the A1C is too high, your physician may opt to increase the dose of one of the diabetes medications in order to get it less than 7. So, the Canadian Diabetes Guidelines in 2018 are very much pushing for a vascular protection strategy in patients who also have heart disease. That means aiming for healthy weight, smoking cessation, physical activity, target blood pressure, an A1C of less than 7%. And these schematics may be quite useful and pleasing for you to remember to integrate these things into your lifestyle. In terms of medications, there's no shortage of drugs that can protect the heart, especially in patients with diabetes. Statins are recommended for cholesterol lowering. ACE inhibitors or ARBs, the second sort of class here, are recommended for blood pressure lowering and heart protection. Certain antihyperglycemics are recommended as well. So it's a lot to know and remember, but the good thing here is that we have the tools that we need in order to get patients healthier. Some of the drugs that protect the heart are the statins, and you may recognize things like atorvastatin, which is Lipitor, or rosuvastatin, which is Crestor, which is recommended in patients with diabetes and heart disease to target their LDL less than 2. ACE inhibitors such as ramipril or perindopril are also recommended for blood pressure control. Antihyperglycemic medications, and lastly, aspirin is used selectively, not for all patients for primary prevention, but definitely for secondary prevention of heart disease in most patients as well. What is new here is that over the last couple of years, the antihyperglycemic medications, the ones that have been discovered and have come to market, have shown much more benefit than the ones that we have been using for several years. That benefit is that these new drugs reach lower A1C levels than ever before. They're more effective than metformin, glyburide, and other medications. They help with weight loss. Some of them result in a weight loss of up to 3 kilos. And they help with your heart health. So these new drugs have been shown to be cardiovascular protective. So, how do we put that all together? Metformin, which is still the gold standard first-line therapy for all patients with type 2 diabetes, has a beneficial effect on hemoglobin A1C, as indicated by the 3+ signs here, and has a benefit, although rather small benefit, in protecting the heart. Over the last couple of years, there are two new classes of drugs, one called the SGLT2 inhibitors, and there's some examples of them here, and the other class called the GLP-1 agonists, and there are some examples of that here, which not only have beneficial effects in lowering A1C, which we want, but further to that are very attractive from a cardiovascular perspective because they have very significant effects on the heart that are positive effects. And the clinical trials that have shown this have really shaped the guidelines and have really shaped the strategies that your physicians are now using for you. This is my only incredibly busy slide, and I contemplated not even putting it in, but I just wanted to give you a snapshot of what these guidelines look like and what your clinicians are using to guide therapy. In patients who have a diagnosis of type 2 diabetes, if the hemoglobin A1C is less than 1.5% above target, first we try lifestyle intervention, and then failing that, after 3 months, we would initiate metformin. In patients in whom the A1C is greater than 1.5%, so significantly above target, we are starting metformin right away and considering a second drug as well for blood sugar control. So many patients actually fall within this middle section here. For these patients, if they still don't reach glycemic target and they do have heart disease, for example, a history of a heart attack or angina, so that would qualify as clinical CVD or cardiovascular disease. These major guidelines are now suggesting that the second agent that you add to metformin be one of these new cardiovascular protective diabetes drugs. And they're making some recommendations. They're suggesting that you could use empagliflozin, liraglutide, or canagliflozin. Those are just a few examples of the possibilities. So for many of you may already be on a combination of metformin and one of these cardioprotective drugs. I want to talk a little bit more about them. One of the major classes that is recommended for cardioprotection are the SGLT2 inhibitors. So there's a lot of acronyms, and especially when we talk about drug classes, that's why we have this alphabet soup of letters. In very simple terms, they work by reducing sugar reabsorption in the kidney and promote its elimination in the urine. And that's how the body loses blood sugar, and that's how blood sugar levels come down, and quite significantly, in fact. A few of these drugs you may recognize are empagliflozin, and the brand name of that drug is Jardiance. Canagliflozin, the brand name is Invokana, and dapagliflozin, the brand name is Forixia, a difficult one to pronounce. So these drugs didn't exist actually before a couple of years ago. These are all new agents. And now we have many, many patients who are receiving one of these drugs in combination with metformin, and they're very well controlled. Why are these drugs so good? They're good because the reduction in A1C is quite significant, from 0.4 to 0.7%. That's great. They lead to weight loss of 2 to 3 kilograms, and they also lower blood pressure, which is often a very welcome effect in many of our patients with heart disease. Further to that, they've been shown in very large clinical trials to be beneficial for reducing cardiovascular outcomes, important outcomes such as heart attacks. Hypoglycemia is rare, and this is great. It's a very positive thing. Many of you may be aware that hypoglycemia is more common with other types of drugs such as glyburide and glycoside, but it is rare with this class of drugs, and so that makes them safer. Some of the side effects that we do monitor for are yeast infections, which occur in higher rates compared to placebo. In females, estimated to be about 10%, and males 5%. Oftentimes, those are treated through without the SGLT2 inhibitor being stopped. This class of drugs also causes an increased rate of urinary tract infections compared to placebo, but that risk is very low. There's another side effect that worth mentioning as well, which is extremely rare, but it's information that you may read up on if you do Google this class of drugs, and it's called diabetic ketoacidosis, and that's when we have an increase in ketone levels in the blood. Now, it's extremely rare, but it's something that we need to be aware of. Some of the triggers of this are when patients become ill and they have decreased oral intake or decreased carbohydrate intake. So during concurrent illnesses, we recommend that if you are taking an SGLT2 inhibitor, that the medication be put on hold until you're back to feeling well and eating normally. We also routinely hold this class of medications in patients who are undergoing surgery because of this risk, and we recommend holding 3 days preoperatively and then resuming postoperatively when eating well. So there are some nuances to remember, and physicians are aware of these effects, especially the endocrinologists, and they are looking out for these things in patients. The other class of medications that is really a game changer in the world of diabetes are the GLP-1 agonists. Some examples of those are liraglutide, which most patients call Victoza, or Ozempic, or Trulicity. So some very catchy sort of names there. These are quite different from the previous class of medications that I just talked about, because that group of medications were all oral pills. These are injections, subcutaneous injections. Easy to administer, and they can be, some of them are given once a day, others now are given once a week. So extremely convenient way to control blood sugar. It mimics endogenous glucagon, and so what it does is the body makes more insulin in response to blood sugar levels. This translates into a significant reduction in hemoglobin A1C of about 1%. So of all medication classes with this group here, we see the best reduction in hemoglobin A1C, very potent, very good control, and a weight loss of 1.6 to 3 kilograms, which is also a welcome effect. Again, hypoglycemia is rare, so they're quite safe. Some of the side effects worth mentioning, or the incidence is very low of all of these, but I just thought for comprehensiveness I would put them down. Nausea, vomiting, diarrhea, which is extremely rare, and gallstone disease, which is also extremely rare. This class as well, similar to the last one, has been proven in very large clinical trials to have a big benefit in reducing cardiovascular events in patients with diabetes. And because of all this evidence now, what you start to appreciate why in the guidelines these agents are now our go-to agents after metformin, to add to metformin for blood sugar control. There's a lot to know and remember for diabetes, and as I was preparing this talk, I came across the Diabetes Canada website, which also has a wonderful resource for patients at diabetes.ca to learn about diabetes, the drugs, and any lifestyle interventions, because it can be overwhelming. And in summary, as a pharmacist, I sort of have this slide with all of my presentations when I talk to patients. It's important as a patient to understand your medications, to know why you're taking each of your pills. It's important to understand the risks and to ask questions when you have questions. The choice of a drug in you depends on many factors. So what I've talked about today does apply to most patients, but there are certain individual factors about you that may make your cardiologist, endocrinologist, or family doctor select a particular drug in your circumstance. Adherence to your prescribed regimen is important for all your medications for heart disease and diabetes. And if you are thinking of stopping your therapy, please don't do so without talking to your physician first. One more thing I forgot to put on this slide is it's very important to try to get your medications all from one pharmacy, because many of you may be aware we are not all integrated, the community pharmacies. So if you wanted to be able to detect things like drug interactions, you could really only do that if you actually got all of your medications from one pharmacy. And that's actually my last slide. Thank you.
So, thanks very much, Claudia. That was very clear. And we're going to have a question period after. At the end, we'll sit around. I'm just trying to think if there's any way, I may do something a little bit unusual here, but from the webcam point of view, if you have questions, you can send it to my cell phone. No, actually, I'll do my email, okay? And see what type of questions we get, just to see if anyone's actually out there watching the webcast live. So it's bradley.strauss@sunnybrook.ca, okay? bradley.strauss@sunnybrook.ca. If you send questions, we will ask them of the panel members at the end. Our next speaker will be Dr. Sam Radhakrishnan, who is the director of the cardiac cath lab at Sunnybrook Hospital, and also very well-known individual in the field of structural heart interventions and coronary interventions. And he's going to be talking to us about TAVI, which is an extremely important procedure that has really been disruptive and revolutionized the treatment of aortic valve disease. And Sam has really been a huge leader of that, not only in the city, but nationally and internationally. So I'm very pleased that Sam has agreed to speak today about TAVI, what's new in TAVI, and I'm sure you'll find it very interesting. So thanks, Sam.
Thank you, Brad. It's always my treat to be part of these community sessions. I think I was originally part of this when we started the STEMMing program here, which was about 10 years ago. And then when we started TAVI here, which was about 10 years ago. And now it's wonderful to talk to you about where we've come with TAVI. And I think the future is quite bright, and I hope you'll agree. So I've titled my presentation, Here Today, Home Tomorrow. What's possible with transcatheter aortic valve implantation, or TAVI, in 2019. But equally, we could call it Why We Are a Minimalist TAVI Center. And I can already see the eyebrows going up, and I see Monica's, I can feel that Monica's blood pressure and Brad's blood pressure is going up. And they made it very explicit here. This is a PG-13 audience. We shouldn't be talking about anything that's too inflammatory here. So it's not really this. This isn't what we're talking about as a minimalist. But it does give me the opportunity to showcase the team here involved. Of course, you know Dr. Strauss, my surgical colleague, Dr. Freems, and my other colleague, interventional colleague, Dr. Wajasundra. And yes, you could probably, the astute people there would tell that this is photoshopped in, mainly because, Dr. Strauss has much bigger biceps than this. So you're right. And we're not going to talk about that kind of minimalism, but we will talk about a different kind of minimalism. So let's step back and ask why we're doing this and talk about the disease process, which is, very briefly, aortic stenosis. What is that? The picture there shows a surgical view of a heavily calcified aortic valve. The aortic valve is one of the 4 heart valves, help the heart pump blood forward to the rest of our body. This is largely a degenerative valve condition. As we get older, our valves start to calcify and harden and narrow. It's quite common. It affects almost 1 in 8 individuals over the age of 75 to various degrees. But the key point here is it's a mechanical problem. It needs a mechanical solution. So it's not something that we can treat with medications to cure the disease. We need to replace the valve. And the reason to replace the valve is really this, and I'm sorry it doesn't project very well, but what you can see is for a long period of time, as the valve is mildly stenotic, there is a lack of symptoms. And you will see that in patients with aortic stenosis. Typically their family doctor hears a murmur, sends them to get an echo. The echo defines that it has an ultrasound of the heart, mild restriction of flow across the aortic valve. You see a cardiologist. The cardiologist says, you're fine, I'll see you in 2 years. We'll follow you yearly or a couple of years with echoes. But at a certain point, when the valve gets quite severely narrowed, then you get the proliferation of symptoms. And once you start to develop the hallmark symptom of heart failure or dyspnea, shortness of breath on exertion, the prognosis with untreated aortic stenosis is dismal, such that the 1 to 2 year survival, once you have heart failure symptoms and severe aortic stenosis, is less than 50%. So much worse than many malignancies. So what is TAVI then? I think I'm pleasantly surprised at how many people know what a TAVI is. For those that don't, here's what it is. This is your aortic valve. We access entry into the aorta from your femoral artery, your leg artery. We put a wire across the stenotic valve. This is all done in a lab using fluoroscopy or dynamic X-ray imaging. We cross the stenotic valve and then implant the valve. In this case, it's balloon implanted, where there's rapid pacing of the heart. The valve is implanted, the equipment removed, and what is left behind in the old disease valve is a new functioning bioprosthesis, a stented valve with tissue leaflets inside. So that's the animation of what a TAVI is. What it looks like when we view it is, and I'm sorry if you can't see it quite well, but maybe the folks at home can see it a little bit better. Here is the access in the right femoral artery. This is a patient's hip bone. We're injecting dye into this blood vessel to see that we're in the right spot. Once we're happy, we'll position a valve. Once we're happy, we'll position a valve across the stenotic valve and implant it under X-ray guidance with contrast dye. And what we're left with then at the end is a functioning bioprosthesis. So TAVI really has revolutionized how we can treat severe symptomatic aortic stenosis, to the point now that when we started, and I gave this talk originally now 9+ years ago, we were only reserving TAVI for the most sick patients, the patients who couldn't undergo surgical intervention. They were just too sick. Now we have indications for TAVI even in the less sick patients, the intermediate risk patients, and we have completed a clinical trial, or part of a clinical trial that has been completed, that will be likely presented in March at a major cardiac meeting, that has looked at, is TAVI now equal to open heart surgery in the low risk patients who otherwise would be low risk for surgery. So stay tuned. Maybe Brad will bring that back in another couple of years. What was a problem with TAVI is this. This is classic TAVI. There's about 400 people in the room. You can barely get enough oxygen in there. This is how we started. You have large numbers of people appropriately. Your patient was intubated. They were on the lung machine. They had cardiac supports. We had the cardiopulmonary bypass machine in the room. It was time-consuming, it was resource-intensive, and it was costly. It was definitely proved its value in the sickest of sick patients, but it was a very costly procedure. Not only was it costly in the procedure itself, this is our length of stay, LOS, in our own population as little as 4 years ago in 2015. And what you can see, excuse me, is that even with this more minimally invasive therapy, TAVI over surgical valve replacement, we still had length of stays that were in the week-long range. So yes, better than surgery, which may have been a week to 2 weeks, but still pretty long time in hospital. So it was tough to accommodate these very expensive procedures. I'm pleased to report that that has changed, and that our program here was amongst the the 13 centers involved in this Sentinel trial that has really changed the way TAVI is being done worldwide. This was the 3M study that was directed by our good friends in Vancouver. But the other thing that we should all be proud as Canadians is of the 13 North American centers, and Sunnybrook's there, 11 of them were TAVI centers from Canada. And I think that speaks to the excellence of care and the innovation that is happening in this country in this space. So what did it do? It looked at, can we simplify the pathway to get patients done in a much more minimally invasive, there's that minimalist term, manner, to expedite the recovery and then ultimate discharge, but of course doing it safely. So the model here is to look at the pre, the procedure, and the post. Anesthesia now is conscious sedation. So the patients are no longer intubated or on the breathing machine, but sedated, often talking to us. The procedure is set up so that it's percutaneous, no longer a surgical cut down to get to that vascular access or the blood vessel in the leg. What that facilitates is to allow us to get the patient up in the chair 4 hours after the procedure and walking later that afternoon, evening. And then the appropriate monitoring to see that we can discharge the patient safely and appropriately in an early timeline. In the trial itself, of these 400 patients that were in the trial, you could see that it was safe and efficacious. The overall 30-day mortality was extremely low at 1.5%, and stroke was 1.5%. And what you can also see that the vast majority of patients in this clinical trial were able to be discharged within 2 days, many within 1 day of their procedure. The 3M study is highlighted here in yellow, and it's compared and contrasted to many national TAVI registries. And what we can see is, I will focus in on the median length of stay as being 1 day post-procedure versus about a week to 2 weeks, where we were at Sunnybrook in 2015. So it really revolutionized our approach to delivering this care. So what are the benefits then of going minimalistic? Of course, streamlining patient flow, reducing costs, and we'll come back to that, reducing length of stay, better utilization of our human resources. That includes physicians, but technicians, nursing staff, both in the procedure and in the recovery areas, and delivering upon improved clinical outcome. So we break this down into the 3 Ps of the pathway: the pre, the procedure, and the post. I'll just go by the pre-procedure, all 3 of these very, very quickly. But pre-procedure, what's very important is you've got to appropriately screen for the patient that can undertake this pathway. And I will say to you, as you get more experience, the majority of our patients now can be part of this pathway, and it's the minority that actually have to spend a prolonged period of time in hospital post. What is crucial to all this, the setup work, is the CT scan and proper imaging to see that anatomically the patient is an appropriate candidate, one for TAVI itself, but secondly to undergo this more minimally invasive approach. In the interest of time, I'll skip through that slide. One of the most crucial things is looking to see, are the legs, the arteries that supply blood to your legs, are they big enough to handle putting in the catheter that then delivers the valve? And that's based on CT imaging. And here too we've made gains over the last 5 years. What you'll see is a number of different clinically available valves in Canada. But what you can see is we've come down in terms of their size of the sheath that needs to deliver them. That's the tube that goes into the leg, from almost 7 millimeters now down to 5 millimeters. That doesn't sound like a huge difference, but it is. It's the difference between a sheath that has to be about the size of my finger and the sheath that can be about the size of a Bic pen. And that makes a world of difference in terms of being able to deliver these valves in a transfemoral, through the leg artery, percutaneous, with a skin puncture approach. Indeed, as we get down in leg size, sheath size, we can now take on more patients. This is particularly important to our female patients who tend to have smaller anatomy and smaller leg sizes. So this is good news. Here's an example of a patient that probably about 5-6 years ago we would have thought differently about doing it transfemorally. Quite diseased femoral arteries, but the sheath was inserted. This is the valve going in under X-ray guidance on the wire, nicely transitioning across the aorta, and this is the valve being carefully implanted under X-ray guidance with contrast, and our final result is excellent. So the transition to smaller sheath sizes has allowed us to go to a transfemoral approach. I'll highlight here the US registry database of transfemoral access, and what you can see on the blue line is that the transfemoral approach in the United States has crept up now from as low as 50% in 2012 to now about 94%. What I can say to you is this is where we were in 2012 at 92% transfemoral. This is where we were in 2016, 98%. And just looking at our data, this is where we were last year, 2018. 99.3% of our patients went through a transfemoral percutaneous approach. So quite valuable for our patient population. The other things in the pre-assessment is making sure the patients aren't anemic, because if they are, then we have the opportunity to increase their blood cell counts. We send them to the blood conservation clinic, and strategies are used, such as giving iron. And by doing this, a quarter of our patients we found needed to go for iron transfusions in advance of their TAVI procedure. And what that has done by building up their own hemoglobin stores, making them less anemic, is it's decreased our in-hospital transfusion rate from 50% down to 7%. So also valuable in and of itself for early discharge, but also valuable for the patient. Of course, when we talk about a minimally invasive approach without intubation or a breathing tube, it means that all of our patients are screened in the anesthesia clinic to assess that they are an appropriate candidate for that approach. The other aspect in the pre-procedure is informing our patients. So we do have a brochure that we put together, and what it very clearly says is your length of stay, you should anticipate that your length of stay is going to be 2 days. That's the median, that's the average, so that there's no surprises here. What about the procedure? Well, we talked about how this was a very busy room. And this isn't my picture, it's borrowed from our colleagues at Emory, but it certainly could reflect what we see in our labs. We've gone from a very busy room with lots of folks to now a much less busy room where we have the right number of people to deal with the procedure and any complications that can occur. And of course, that has simplified our procedure and decreased our resource utilization. There are other things that you can optimize, such as how do you get that actual puncture perfect so that there's no bleeding. And this is a paper we put out from our group, our experience, showing that ultrasound guidance really lowers our complications with the puncture by about 50 to 70%. Finally, the post-procedure, we've developed and crafted pathways here that make it very standardized as what's expected for your recovery following your TAVI. And what I'll highlight is that you can see it's broken down to post-procedure day 1, post-procedure day 2. And the key points here are we are getting rid of any intravenous lines or any access points, mobilizing the patient so that the recovery process starts even that first day. So if we go back to where we were in 2015 with a median length of stay between 5 to 8 days, now what we've seen is we've brought down our length of stay to 2 days post TAVI, with a significant minority being able to go home the next day. I think that's a real boon. Forget about to the way we deliver, it's a real boon to our patients. What is important is doing it that way has reduced our costs compared both to surgery and the way we did it before. So this is data from one of the clinical trials that we participated in. This is US dollars and US costs. But what you could see in 2015 is TAVI was more expensive than doing surgical aortic valve replacement. I can showcase that indeed Sunnybrook was quite good in terms of the way we do surgical valve replacement. These are converted to US dollars to stay on the same scale. But that in 2018, 2019, we do TAVI at a much more cost-efficient manner than we do surgical AVR. So that's a real boon. It's a boon to patients. It's a minimally invasive procedure. It gets them home earlier, and it's being done for less expense to our burdened healthcare system. So the take-home message then is that implementing this minimalist approach is both feasible and contemporary best practice for 2019. That adherence to the pre-procedural and post-pathway is actually pivotal to improved clinical outcomes, and this makes it a cost-effective procedure and necessary as we anticipate increasing demand for TAVI. The final slide I will leave you with is a breakdown of the burden of aortic stenosis in our population that we're seeing. About a third of those patients now are high-risk patients, which we are doing currently TAVI on. Another 15% are intermediate risk patients, so not high risk for surgery, but not low risk. And there is a clinical indication for that, which we hope to see funding approved for. But the bulk of what is remaining is the low-risk population. I've already highlighted that there will be those trial results released in the low-risk population comparing TAVI to surgery. We wait with anticipation, but our strong sense is that this is where TAVI will be heading next. So the demand for TAVI is going to be growing. Our ability to service our patient population will need to keep up. Thank you very much.
So, Dr. Radhakrishnan, I know that you have to go to a hockey game.
My sons, not the Leafs.
Not the Leafs. Okay. So, are there some questions from the audience or anyone who wants to email me? Are we going to write them out, or go ahead? Just, you have to talk really loud. I'll repeat it for you.
High risk, would that equate with a severe aortic stenosis?
So I'll just redo the question so everyone can hear it. So the question is, what exactly is meant by high-risk aortic stenosis? Does it mean that it's worse aortic stenosis than someone who has low-risk aortic stenosis?
A wonderful question. It means I didn't explain this well enough. Patients can be described as being low surgical risk, which means that they have bad aortic stenosis that needs to be treated, but they're actually a good operative risk. On the other hand, because of multiple comorbidities, age, frailty, you could be non-operative with your severe aortic stenosis, or you could be a high surgical risk. 10 years ago, we would have undertaken that high-risk surgery because the outcomes of medical therapies alone, so not implanting a new valve, are dismal. So we would have undertaken that higher risk. Fortunately now, we know that TAVI is a much better approach for the non-operative and high-risk patients over surgery. It's at least as good, if not better, as an approach in the intermediate risk patients. And we will have data soon on the low surgical risk patients as to whether TAVI is comparable or better.
So maybe I'll ask you, Sam, to clarify perhaps what is the difference between what the studies have shown already and what is actually allowed for in terms of the funding that we have, because we have very strict guidelines of the patients that we can treat with TAVI, and it sometimes lags behind the data that comes from clinical studies. And that's not just in TAVI, but in general, that's often in cardiology, that the data is out in front of what the funding is about. So maybe you can comment on that and who's actually getting it now and waiting times, et cetera.
Yeah, so that is a crucial challenge now that we're seeing in the Canadian context. In this province, TAVI is funded and funded for patients who are high and inoperative, and that's because the data is there to support that. Many of the individuals you've seen on the slide that I talked about, the TAVI team, my colleague Dr. Wade Jasundra, have been involved in making an advocacy to the ministry through Core Health Ontario to encourage that TAVI be funded now for intermediate risk patients. And that recommendation has gone through, and so we'll wait to see on the funding for coming up shortly. There is a lag time. It is fair to say that in the United States in 2016, where they did get approval, FDA approval, for TAVI as an option for intermediate risk patients, and funding associated with that in 2016, the number of TAVI procedures in the United States surpassed the number of surgical aortic valve procedures. We saw that in many countries in Europe, actually a couple of years earlier. Unfortunately, Ontario is not there yet, but I will say that there is a renewed sense that this procedure is good for patients. It's better in many respects than surgery. It gets them home. And the way we've talked about today, it's done in a more cost-efficient manner than surgical AVR. So I think there's a much larger renewed interest in saying, let's look at what the appropriate funding is. And that's a good thing.
Let me ask another question, because I think it's interesting that one of the complications of aortic valve surgery and even of TAVI is stroke, which is, of course, can be a devastating result when it does happen. There's a lot of work being done internationally about various types of devices to prevent the embolization, or at least the embolization to go to the brain. But it's somewhat controversial, and I think some sites, particularly in the US, are using a lot of these devices, and many other sites use very little of them, including our own. Just want to get your own comments on what you think about the risk of stroke with this, and do you think there's a place for some of these other devices that may actually impact on it?
Yeah, it's a great question. So one of the big complications with surgical AVR and TAVI is a risk for stroke, and it sits around 2%, 1.5 to 2% with both procedures. It's pretty clear in the TAVI population what's driving that, which is as we implant the valve, that process of implanting the valve into the stenotic calcified old valve will liberate plaques that can go off and cause strokes in the brain. Fortunately, that risk, or that clinical risk, is low, but that has spurred the development of these protection devices or filter devices, which we can implant, and at least in large series of trials that suggests that there's a reduction in these small hits to the brain. So I think there's a lot of appeal to this technology. It is a challenge because clinically there hasn't been a massive drop in the stroke risk because the stroke risk is already very low. But I think there is definitely appeal. We don't have these filter devices approved in Canada yet. That likely will come within this calendar year. And I do think that you'll start seeing them used, as in the United States, in a significant minority of our cases.
So there are some arms were up before about some questions. I didn't want to cut you off. Yeah, please.
Is there the development of a valve like this for mitral valve disease?
Good question. Very good. Okay, there you go.
That's a fantastic question. So the mitral valve is a bit more complex an apparatus than the aortic valve. The aortic valve lends itself quite readily to a percutaneous device or a minimally invasive device because it is really all the action is within 2 centimeters of where the valve is. The mitral valve has many more parts that can go wrong. Both in terms of how the heart is pumping, the attachments of the leaflets, the muscles that hold the valve in place. So it is, in fairness, a much more complex apparatus, and it will require more complex solutions. There is a wealth of innovation and technology under assessment, both to deal with parts of the mitral valve and the mitral valve in its entirety percutaneously or minimally invasive. We haven't seen that breakthrough technology yet, although we certainly have a good technology for dealing with, in the appropriate patient, severe mitral leakiness, which is the mitral clip. But the replacement in terms of a whole valve replacement, we haven't seen that breakthrough yet, but I suspect it'll be coming. One last question at the end there.
The valve that you implant, where do you get it from?
Okay. So there are a number of, at least 3 different types of valves that are medically approved in Canada. And briefly, they all are a stented prosthesis, so some metal frame that within them suspends leaflets, either bovine tissue leaflets, leaflets from cow pericardium formed into tissue, or porcine pericardial leaflets from pig pericardium tissue. So in essence, the concept is similar. There are some differences between the platforms that exist, and at Sunnybrook we use all 3. We've certainly been a leader in at least 2. Yeah.
So, I make a point that congratulate Dr. Radhakrishnan and his team that you can see that TAVI is more than just a valve, right? I mean, we had the valve, 5 years ago, 8 years ago. It's much better now, I think, in terms of the size. But where so much of the progress has come in the last few years is actually how to assess patients more, how to inform them better, and how to plan the procedure, not just inside the actual procedure itself, although there have been great strides there, but just the pathway of the patient as they move through prior to the procedure, during the procedure, and after the procedure has made really a huge difference in how the care is delivered, the cost of the care. And it just shows you that it's not just about the technical innovation, right? It's about so many other parts that at first you don't think about as a patient, but actually have as much impact on how much of this particular innovation can be delivered and how it can be done in a way that really meets the challenges of our healthcare system. So I congratulate you, Sam, on the outstanding work. And the only thing I would tell you about that picture is that I know that it wasn't me, and that's because that's not the kind of stethoscope that I use, so I was quite sure that. But anyway, thanks and good luck with the Leafs tonight. I hope you score a few goals.
Your smells great.
Okay. So our final speaker of the evening is Dr. Ahmed Casey, and Ahmed is a remarkable young physician who's joined us. I think now he's almost finished his 2nd year here with us, right? Who is a vascular surgeon. He's multi-talented. He spent some time in the States doing some specific training on how to treat ulcers in the lower leg and how to save legs that are otherwise at great risk of being amputated. He's a very creative individual, has many ideas on how to do things in a different way, including inventions. And outstanding surgeon and endovascular operator as well, so these vascular surgeons not only do surgery by using their scalpels, et cetera, but they're also in the cath lab. And it's very interesting for us in the Schulich program to have vascular surgeons work beside us in the cath lab, which is quite an unusual model in healthcare, where the vascular surgeons work in the same place as the interventional cardiologists, and we learn a lot from them, and hopefully they pick up a little bit from working close to us. But Dr. Casey's going to talk today about treating leg ulcers, which I think is a really important topic, and most of us in medicine do not know very well on how to treat these ulcers. So I think it's a really important topic, and we look forward to your input and education there. So thanks, Ahmed.
All right. Okay. Thank you very much, Dr. Strauss, for the very generous introduction, and thank you all for coming here tonight and braving the weather. Very honored to be here for the second year. So, you know, we have something very special here at Sunnybrook under Dr. Strauss's leadership. It's one of the few places I'm aware of anywhere in North America, really, where there's such a close collaboration between different disciplines in the Schulich Heart Program. So we don't work in silos, we work as a continuum, and I think you've seen some of that tonight. My talk is going to be about just a sort of a slight segue about wound healing and the role of the blood vessels in healing your wounds, and to basically talk about how wounds heal as well. So I work as a vascular surgeon here. I'm also a wound care physician at Women's College, but also here. So I see a lot of wounds in my practice. It's something that I am very passionate about. So I do have a couple of disclosures. I have no financial disclosures. However, I'm going to be putting up a lot of disgusting photographs. So no fancy videos, unlike my colleagues, but please be forewarned. So what are we going to talk about tonight? Very briefly, what are the different types of ulcers? How do ulcers heal? You know, when you injure yourself, how do you actually heal? And how can we optimize or improve the blood supply to an ulcer to help it heal faster? And just some bread and butter advice to all of you on how to avoid getting leg ulcers, which are a very serious problem in our society. So basically, what are the different types of ulcers? So enter disgusting pictures. Really, when we think about leg ulcers, we think about the cause, what we refer to as the underlying etiology. So what is it that is causing the leg to develop an ulcer? Well, is there not enough blood reaching the leg? We call that an arterial ulcer. The arteries are the blood vessels in your body that carry the blood from your heart, that lovely heart that Dr. Strauss and his colleagues have fixed for you. Well, it's got a function, and one of its functions is to send blood all the way down to your toes. It does so in arteries, and when you don't have enough blood reaching your legs, you develop an arterial ulcer. That is what it looks like. So how can I tell that this is an arterial ulcer? Well, there's no magic wand. I look at this and there's an ulcer, but I also look at the rest of the foot. If you see here, there's some redness here. We call that erythema. There's some early signs of gangrene in the toes. That's also a hallmark of arterial ulcers. So it's really a whole picture approach. It's not just that I look at the ulcer and I can tell. Okay, so that's one of the main types of ulcers that we deal with. Venous ulcers, on the other hand, look quite different, and I'll explain to you why this is different from the one that we saw previously. So if the arteries carry the blood from the heart to the toes, well, the veins carry the blood from the toes back to the heart. It's a two-way system. And if you've got too much blood pooling in your legs because your veins aren't working properly, you start to get swelling. So if you can see here, well, you can't really appreciate it in this picture, but this leg is swollen, and you start to get a pooling of the blood that causes the blood products to break down and start to change the color of the skin around the ankles. So if you see here, I don't know how well that projects, but the skin in that area is brown or darker than the rest of the skin in the surrounding area, and we call that brawny induration. So the blood products break down, the red blood cells break down, and the iron in your blood starts to cause sort of like a chemical reaction that causes the skin to be brown in color. So that's a venous ulcer. And then you get lymphedema type ulcers. So the third, and I do apologize if this is shocking, but lymphedema is a condition where your arteries and veins are working okay, but you've got too much fluid pooling in your legs. So that's the lymphatics are the third mechanism that we use to transport blood products and fluids back and forth to our toes. So how is this different? Well, this is very clearly lymphedema, take my word for it. You have a lot of swelling, and the swelling causes the skin to become so tense, it's like a balloon. There's very little blood reaching the skin cells because of all this pressure. And that causes skin breakdown, and it causes ulceration. And then finally, and this is where I spend most of my time, diabetic foot ulcers. So that's the fourth category of ulcers that we look at. And diabetes is a very, very big problem in our society and around the world. That's the topic of many different talks that we can give, but I'm mindful of the time. So how is this unique? Well, diabetic foot ulcers occur in areas of high pressure because diabetics lose the sensation, lose the ability to sense with time if there's friction or if there's pain or if there's tissue breakdown on the soles of their feet. So those are particularly difficult ulcers to heal. So that's sort of a flavor of what we mean when we talk about leg ulcers. So they're not just a sore on your leg. We really have to figure out what's causing them and how we can fix them. So how do ulcers heal, or how do wounds heal? Well, this is very, very basic, but really when you cut yourself or when the skin integrity is disrupted, the first thing you do is probably bleed, right? That if you go back to the last time you injured yourself. And the first stage of wound healing is what we call hemostasis, meaning the blood products in your body come together to stop the bleeding and to allow the healing process to start. Hemostasis is really the process of forming a blood clot. And I'm looking for my mouse, which is, anyway. So you've got the hemostasis phase that starts immediately, and it can last for up to 48 hours. So it can take you a couple of days, actually, to stop bleeding. Once that's done, you move on to the inflammatory stage. That's when you get that red, hot, wound that bothers people and is painful. That's where a lot of the pain comes from, the inflammatory reaction of the body. That can usually last up to 72 to 96 hours, and most of the time it settles down. And then you get into the proliferative stage, where your body is actively repairing the wounds in your body and replacing it with other products to heal the wound. That can take up to 14 days. So if anyone here has ever had surgery and has had stitches and has had their surgeon or family doctor remove the stitches in 2 to 3 weeks, the reason is because we want the proliferative phase of healing to finish before we remove the stitches so that your wound doesn't break down. Does that make sense? And then finally, you've got the remodeling phase. That can take up to 2 years, where slowly you form that scar, but your skin never actually goes back to 100%. The maximum it's going to be at is about 80 to 90%. So your skin is always going to be weaker than before you formed the ulcer. So in terms of chronic ulcers, these ulcers that never go away for years and years at a time, and I see those in the wound center all the time, those are ulcers or wounds that are stuck in the inflammatory stage. Okay? The body is just unable to stop the inflammatory reaction to the ulcer for a variety of reasons, whether it's uncontrolled diabetes or poor vascular supply or too much pressure from a venous incompetence. So in essence, there's a $20 billion a year industry centered around getting the body out of the inflammatory stage, and that is the wound care industry. That is all they do. They're trying to get you out of that inflammatory stage. Once you're out of that inflammatory stage, you start to heal. So it's really as basic as that. So okay. So here's a question. Why don't we just leave all ulcers exposed to air? We talk about bandages and wound care products and all sorts of stuff that you or someone you know might have had done. And really, the reason is if the concept of healing a wound has to be around maintaining moisture balance. If you're drying out wounds as much as possible by exposing them to air or by putting iodine on them or all the sorts of stuff that people like to do, you are actually forming a scab. And the scab does not mean, just because you've scabbed over a wound does not mean you've healed it. Okay? This is a very important concept for you to know. If you have moist wound healing, which is the picture on the right, where you have moisture balance, where you've addressed the need to not dry out the wound, then you get much better wound healing compared to the left where you've got a scabbed out wound. So why is that? Well, if you have an open wound and you've formed this scab and you have this dry exudate, what you end up doing is actually impeding the ability of your healthy skin to bridge and to form that proliferative stage. So a lot of times in the wound center, I'm actually removing these scabs to show people the ulcers that are still there, okay? Just because it's dried out doesn't mean you've healed. This is a very important concept, especially in the leg. I think it's because when people are younger and then they're on the playground or whatever, kids, you just sort of put some iodine on it and you move on. Well, that's because their body is constantly in the proliferative phase. We're not, I don't think anyone here is in that stage anymore, right? So you gotta please get away from painting iodine on everything that you've hurt or injured, because you're actually hurting yourself. So most wounds should reduce in size by about 40% at 4 weeks or more. That's the natural trajectory. Wounds older than 3 months or are not responsive to wound care should be biopsied, because we worry about things like connective tissue diseases, chronic inflammatory states, or cancer. And then if the wound bed is worsening despite treatment, then we need to consider infection as well. Okay, so back to the heart part of it. We talked about the importance of infection control and moisture balance and wound care products, but really you need to have adequate blood supply to an ulcer for it to heal. It's just not going to heal if it's deprived of nutrients or oxygen. So how can we actually measure the amount of blood that is reaching an ulcer? Well, an ultrasound is one of them. We routinely arrange for ultrasounds to look at the arteries and the veins around the area of the ulcer to see if all the blood vessels are working properly. What we call segmental blood pressure measurements. So just like when you have your blood pressure cuff put on, we can put that on your leg or on your toes to determine how much pressure of the blood is reaching the ulcer. And then we can measure the actual concentration of the oxygen in the skin. So we call that transcutaneous oxygen tension. And then there are also laser Dopplers and skin perfusion pressures. These are not things that we do here in Canada routinely, but that exist in other healthcare systems. So this is what a Doppler study or an ABI measurement looks like. So, oh my goodness. Okay, let's see if this is okay. All right. So how can we improve the blood supply to an ulcer? Well, one of the options we can do is what's called angioplasty. It's similar to what Dr. Radhakrishnan was talking about earlier, where we do an angiogram, we look at the blood vessels, he looks at the heart vessels and the valves. We can also look at the vessels in the leg, and that's called an angiogram. If we do an angiogram and we note that there is a blockage in the artery, like that, the left-handed, the left side image. If there's an artery blockage or narrowing, then we can actually use a balloon to open it up and improve the blood supply that way. It really is as basic as plumbing. You've got an area that is blocked, you cross it, you expand it, and you're done. Sometimes you're in a position where you have to put a stent in. We try not to do that if we can help it, but there are indications for that. So I'll give you an example. In this case, you're looking at the femur. So this is the thigh bone, and blood really should be traveling from the top to the bottom towards the patient's toes. And I don't know if you can appreciate it. I wish my mouse was, oh yeah, there it is. It's resurfaced. So there's an area, oh. Uh-oh. Okay. Yeah, no problem. So there's an area here where there was a disruption of the flow, and we were able to cross that. I'm actually almost done, so it should be okay. We were able to cross that area of blockage, with a wire and then got a balloon across it, and then after the balloon, the column of contrast flowed right into the leg, and that resulted in healing of the wound within a couple of weeks. So it really is quite spectacular how quickly people can respond once we've improved the blood supply to their legs. The alternative, if we're not going to use what's called an endovascular or a minimally invasive, I actually like this better, you know. If we're not going to use an endovascular or balloon-based therapy, the other alternative is what we call open surgery. So we actually bypass the area of blockage in the leg with a prosthetic or a vein graft. And it's literally as basic as carrying blood from point A to point B across an area of blockage. Okay, that's what we call a bypass. So you can use a vein. That's what we prefer to use every time because we know from studies that it lasts longer. Or you can use a piece of Dacron or EPTFE. So if you think about your Gore-Tex jacket, it's the same stuff, same company that makes it. And you can use that Gore-Tex into a tube and bypass the surgeries, the blockage. So that's really, those are the two broad ways of thinking around bypassing or improving the blood supply. And really, the results are sometimes really cool. Like within a week or two, wounds that have been open for years can start to heal. We see that all the time. So I think the take-home message is that when you're healing wounds, you got to really think about the big picture. So if you're diabetic, you got to optimize your diabetes. By the time you have the wound, there's a lot of different stuff that has happened to you. The wound is sort of the last thing. It's the tip of the iceberg. You got to really start from the bottom up. So a few practical tips about preventing wounds. So if you are diabetic or your loved one's diabetic, you really have to optimize your blood sugars. I can't tell you how many people come in with years of wounds in their feet and then their hemoglobin A1C is like 10 or 11, very poorly controlled, very non-compliant, and then they're upset that the wound won't heal. Well, you gotta start with the basics, okay? If you are diabetic as well, I would strongly encourage that you connect with someone who inspects your feet on a regular basis. We call them chiropodists or podiatrists in our healthcare system. You should have someone look at your feet at least once or twice a year. Okay, look at the quality of your skin, look at your nails, and take care of them for you. They're all over the place in Toronto, and it's the best investment that you can make. The other thing that I would caution you to take care of, especially the men, is moisturizing your skin. I see that all the time. There are some very expensive and fancy moisturizers on the market. Honestly, the cheapest and best stuff is Vaseline, good old Vaseline. Buy it on sale at Shoppers. It works better than any other moisturizer, honestly. And I can't tell you how many times a week I prescribe Vaseline for my patients. And people are shocked. I'm saying Vaseline. That is the easiest and cheapest thing. Men hate it because it's oily, and that's the other thing. If you work in a profession or where you're required to be on your feet for many hours, especially if you're in the healthcare industry or anything else, or if you're up on your feet because that's your lifestyle, I would strongly recommend that you get some sort of compression stockings. Very, very important, especially if your legs are swollen at the end of the day, okay? They don't have to be the very tight ones. And listen, I practice what I preach. I wear them every day, all the time. Yeah, no, you're not missing much. So compression socks are very important. Buy them over the counter at Shoppers or Starkman's or any of those places. Or if you want, get your family doctor to write you a prescription for therapeutic ones. That is a very, very good investment that you're going to make in your quality of life. Because if you have lymphedema, if you have varicose veins, there are 300 or 400 million people with varicose veins around the world. I'm one of them. It's a genetic thing, and you just wear compression and you carry on. Okay? It will not make it go away, but it will stop it from getting worse. Okay? I'm happy to talk to you about that later on. But absolutely, there are things called diabetic socks that. Anyway, we'll get to your questions later. But so I talked about. Sorry, I'm mindful that I'm running out of time. Okay, thank you. That's cool. Okay, so good. Moisturize your skin often. Vaseline is your go-to. Another one is called Urosec. If you get itching, or if you get a lot of itchy skin, Urosec has urea in it. Very, very useful. Wear compression stockings, please. They're all over the place. They're cheap. Just do yourself a favor. And then control your blood sugar levels. And proper shoes. Okay. So the fancy, nice European shoes that look really good are nice to look at, but if you have diabetes, or if you have, if you have very broad arched feet, then you're setting up yourself for an ulcer. The first thing I look at in the wound center when someone's referred to me with a foot ulcer is the shoes. I don't even look at the ulcer. I just take the insoles out, and I can show the person right there and then why they have an ulcer before I even talk to them. So New Balance makes some really nice diabetic footwear, and obviously it's not for ballroom dancing, but it's better than having an ulcer and having your leg, losing your leg. Then get routine foot checks. We talked about that, and that's it. Thank you very much.
Thanks, Dr. Casey. Great to have the audiovisual people helping us out. Do you want to see if we can get the picture on them at all, or? Let's see. Well, I don't want it on me, but those two are young and much better to look at. So we're going to open it up for questions. Certainly, if you want to write them on do we have cards or anything, or just you got some cards, Monica? By the way, I want to thank Monica in the back there and all of her helpers, all the volunteers for helping out today. We really appreciate it. Thank you. And I also want to, before we just say it here now so I have the chance, the importance of learning from our patients, we want to remind you of our weekly Sunnybrook blog called The Personal Health Navigator, written by Paul Taylor and published on our website. Blog provides advice to patients about the hospital and their health care, and relies heavily on medical and health experts. You can send your questions to Ask Paul, that's one word, Ask Paul, at sunnybrook.ca. Want to thank all the speakers in advance of the end of the evening for spending the time preparing these great presentations. And just let everyone know that you can complete the evaluation forms on the way out, pick up free parking voucher, and for all those people at home not getting a free parking voucher, well, you've just missed out on maybe the greatest investment that you could have had, since it's quite expensive here. And please visit the Sunnybrook website at www.sunnybrook.ca for updates. So here we're going to start. I'm going to ask a question. I have one or two for them too I have been wondering about. So I see a lot of patients with leg edema, leg swelling, and they usually get sent to me because, do they have heart failure, which almost all of them never do. But the one thing I find always a challenge is trying to determine whether it's related to venous disease or lymphedema. And the question I have, lymphedema, you show the picture there. First question I have is, does it matter whether it's one or the other, and how do you advise patients differently? Because lymphedema seems to me something so impossible to actually get rid of, other than taking the stockings, but and just a more severe form of edema than you usually see with venous one. But maybe you can just talk a little bit about what the differences are between the two and what treatment options we have.
Absolutely. Is this working? Can you guys hear me? Or?
And I think you have to press the button.
I have to press, okay. It helps to read the instructions. Sure. So the question is there a difference between lymphedema and other causes for having swelling in the legs, and does it really matter? So really it comes down to what is the underlying reason for the swelling. So the lymphatic system is separate from the vein system, and both of them are charged with carrying fluid back to the heart. So academically, there is a difference. I think clinically or practically, there isn't, because the management's very similar. So there is venous insufficiency or venous edema, there's lymphedema, and there's something called, just to confuse matters, phlebolymphodema, which is mixed. So you have both venous insufficiency and lymphedema. The management for both is adequate wound care if there's a wound, moisturizing the skin, and I can't overemphasize this enough. and compression therapy. Now, in lymphedema patients, I tell my patients to treat this as a palliative condition. So this is going to be a lifelong thing. You're just going to have to readjust your lifestyle, and there are interventions to improve your quality of life. So in addition to the stockings, there are what's called deep tissue massage. So there are clinics around town. I work with someone downtown who's really excellent. She and her partner are very much into this deep tissue massage therapy, and patients really like it.
Is that the wrapping? Like I have
No,
some patients.
no, it's
Wrapping
actually-
is different.
Wrapping's different, so we can talk about that too.
Maybe say a few comments about wrapping, because I've asked a lot about
So
that.
deep tissue massage is it's like a massage, but it's quite painful, and it's like they squeeze the fluid out of your legs, and they spend hours doing it, and you get some palliation out of it, so that people come out of it feeling better. But the reason many people get referred to Dr. Strauss is because we usually, before we give a diagnosis of lymphedema, want to rule out or exclude other causes for having a lot of fluids in your legs. One of the most common being is heart failure, but also kidney disease, liver disease, certain infections can all cause that, and obesity as well. So we've managed to cure a couple of people of lymphedema actually after bariatric surgery, where they lose 150, 200 pounds, and the legs are not swollen anymore. So we got to rule all of that out before we give them that sort of title of lymphedema and just say, look, you got to carry on. In terms of treatments, I'm sorry if I'm talking too much, but I think someone asked about the role of surgery. If it is isolated venous insufficiency and the lymphatics are okay, then in a certain subset, and I should emphasize just a certain subset of people, surgery might be helpful in reducing the swelling. So there's a lot of ifs and buts. We got to make sure that there's no clots in the veins. We got to make sure that the deep veins are doing well. And if all of those things are in place, then you may actually feel better with surgery to remove the superficial veins that are causing the swelling to happen. But I am very careful to make sure people are aware that the chances of a complete cure are quite small, because there are tens of thousands of veins in your legs, and guess what? You take one out, the rest are just going to compensate. So you got to really approach this as a lifelong condition that you're going to just manage and carry on.
And to make a difference whether it's laser done or surgically done, what are all these different methods of doing it?
Yeah, absolutely. So the idea is, how do you take the superficial vein, which is the saphenous vein, out of circulation or stop it from being congested with blood? You can either physically remove it, we call that stripping. So we make a cut in the groin and a cut at the ankle, and we literally strip the vein out. It's as sort of barbaric as it sounds. So it takes about half an hour, and the patient goes home the same day, but it has a lot of potential complications, so I actually hate doing it. The alternative is what's called venous ablation, which is just a fancy term for cooking the vein from the inside. So you're not stripping it out, but you're actually clotting it off, so that you're not having that blood flow problem anymore. That's an outpatient procedure. It's a small IV that's placed in your vein, and you also go home the same day. It's not covered by OHIP, so that presents a whole bunch of different challenges. But that's been shown by numerous clinical trials and analyses to be equivalent to the stripping procedure, but not have the same morbidity of having someone rip a vessel out of your body.
Okay, so, and of course the veins there are important because those are bypasses for surgery. So,
well, it's interesting.
but these
you
are
should say
probably
that.
not. Can they ever be used? Any of these veins for?
Well,
Usually,
yes, they
yeah.
can. So where I did my fellowship in Northern Virginia, it has actually the second highest rate of cosmetic varicose veins ablation in the U.S. after South Beach, Miami. And they're cardiac surgeons. They have a world-class heart and vascular program, and this is actually a topic at rounds. A lot of their patients don't have veins that they can use. Wow. I mean, we joke about it, but this was something that people were talking about, as a problem. So yes, please don't have people cook your veins if you don't absolutely need to.
Okay, so a question for Claudia. With these new diabetic drugs for cardiac patients, if you're a cardiac patient, you're not currently on Jardiance or some of these newer ones, should you be on it? And if so, who should be taking it? And what do you do about all the other medications you may be taking for diabetes?
That's a great question. So some physicians have more experience than others with the new agents. There's a bit of inertia, as there always is when new drugs become available. But practice is really picking up. I'm seeing more and more patients who are being taken off their glyburide, glycoside, gliptin, like sitagliptin, linagliptin, glitazone medications. I'm seeing more and more of those drugs being discontinued and replaced with one of the new agents that I talked about today. So if you're currently not on one of these agents, I think it's worth bringing up with one of your physicians and to determine whether that's an alternative for you. The metformin is going to stay as part of the combination, but the question is, what is the best perfect second drug for you for diabetes? And so whether it's your family doctor, cardiologist, or endocrinologist managing that, I think it's a worthwhile discussion point to bring up.
So maybe related to that, and I'm not sure you'll appreciate this question, but would changing these drugs in any way improve the circulation and improve sex life? So, important question, of course, because that is a major problem with diabetes in the vessels. So, where does the advantage come in for taking these drugs?
Well, the advantage comes primarily with improving A1C level and blood sugar levels, and secondary to that, and avoiding all of the complications of diabetes, whether they be complications related to the peripheral nerves, related to the eyes, etc. So I would assume, although I haven't seen that data in clinical trials, I would assume it definitely wouldn't have a negative effect on sexual function, but I don't know that was one of the endpoints that was studied in the trials. I don't know if you know.
So assumingly we're talking about erectile dysfunction, and so this is a very important topic, and it's underappreciated and under-discussed. So one of the problems with diabetes is that it really is a triple or quadruple threat, right? So it attacks your arteries, it attacks your veins, it attacks your nerves, and so part of that is that it affects all small blood vessels, and guess what? There are small blood vessels in the sexual organs. So yes, we know that impotence is a big problem in this patient population, and really just to go back and stress the importance of blood sugar control, because you're not going to make the disease go away, but you can slow down or even bring to a halt the destructive process. So I don't think that you can. I'm not a urologist, but you will not be able to enhance function, but you can stop the sort of slippery slope of getting worse and worse.
Yeah, I think it's incumbent upon all of us and patients with diabetes to, everyone I think has started to learn what their cholesterol levels are, right? The LDL. Probably you should equally know what your A1C levels are, because that's a extremely important education one in terms of controlling the diabetes and making sure that you're doing everything optimal. So I would really encourage the patients who are either watching through the web broadcast or here in the audience that you should really start to become familiar with the numbers for your A1C and your LDL cholesterol, because I think they're equally important in terms of treating your disease. Here's one for Ahmed. The varicose veins, what about neuropathy, tingling on the feet, pins and needles? Do varicose veins cause tingling or should you be looking for other causes here? Or?
Yeah, so it depends what you define as tingling. I mean, different things feel different to others. There's definitely, we know that when you have varicose veins, the problem really is not the veins. It's the inability to shift the blood back to your heart. Okay, that's the essence of the issue. It's not the veins. It's that the highway that you're using is broken. So you've got all this blood that's pooling around, and then when the blood breaks down, it releases iron, and so you have like a rust effect. Really, it's the same color as rust because it's iron, it's oxidized iron. Okay, so that can cause all sorts of reactions on the skin, and one of them is a lot of itchiness, and yes, some people will describe that as tingling. So the treatment for that is compression. You want to squeeze all the stuff out of your legs and your feet back to your heart. So there are creams that you can buy, the urea-based creams, but they don't. Ultimately, it's all about compression.
Okay. Claudia, can you comment a little bit about the cost of the new diabetic drugs for patients that are, what are covered by the plan and what isn't, and if you're under 65, what it will cost you to take these new meds?
Absolutely. So if you're a senior citizen over the age of 65, one class of the new drugs is covered, and those are the SGLT2 inhibitors. And those are the pills. So those are covered by the Ontario Drug Benefit Program. But the GLP-1 agonists, the injections are not. Maybe one day they will be, but right now they are not covered, which is unfortunate on the Ontario Drug Benefit Program. So for patients paying out of pocket for these medications, you're looking at about $100 to $150 per month for the SGLT2 inhibitors. And for the injections, the price is quite variable, but $300 and up per month.
And any titration of the dosing?
Yes. So they both classes of medications can be titrated, especially the GLP-1 agonists, the injections. We tend to start with very low doses, and they're set pre-filled syringes. So if one dose is not enough and your prescription would then be increased to another dose, you'd get a whole new syringe, and so we tend to titrate up with those.
And do you think any weight loss trials in and of themselves, separate from diabetics, will be, is there any future in that as a drug loss or drug weight loss program?
Yeah, I mean, that's interesting. I don't know too much about weight loss. I believe that one of the GLP-1 agonists, liraglutide, is now routinely being used for weight loss in certain cases as well. But I have to admit, I'm not up on the weight loss literature. But maybe one day.
Okay.
Yeah.
Okay. Yeah, sure, please.
Those are my questions. Thank you very much.
Good.
TCC is waiting for me, France. But I have a question here. Lipitor.
Yes.
I don't even know this guy, a well-known guy, Dr. Bruce Perkins from the Mount Sinai Research. He's my diabetes specialist.
Okay.
My A1C is really 6.1 to 7.1. Every 3 months you move it. You said Lipitor, the good guy is low. 1.8 or 1 point something. And the bad guy is very good. He's all the results. Creatinine, everything is good. But now the man put me on 80 milligrams of Lipitor. Why? He says there's something new now that all the specialists, everybody doing that. And I was at 40 milligrams.
Okay.
So the question is, why would doses of some of the statins, which seem to have fairly good control of your LDL, or at least what you've been told, be asked to be increased? And it sort of offers a little bit about the issue that we now appreciate that the lower the LDL levels, the better it is for cardiovascular health. So maybe you want to talk about, Claudia, some of the, as it relates even to the PCSK9 inhibitors.
Yeah,
so.
definitely. So the cholesterol targets differ from one person to the next. So never compare yourself sort of to your neighbor. Targets are more aggressive. LDL targets are more aggressive in diabetes and patients with heart disease. So generally we're looking for an LDL of 1.8 or less. And in fact, more recent data tells us that the lower you go, the better. And we now have data suggesting that an LDL closer to even just 1 is better than higher. And so that's probably the rationale for the dose increase.
I don't know if coronary disease is an issue there or not, but certainly in patients with coronary artery disease, up until about 2 years ago, the Canadian targets were basically get someone down with an LDL to 1.8 or lower. So now you have these new agents that really lower the LDL much lower, 60% reductions, even beyond what they're on statins.
Yeah.
And it's a category called PKS9 inhibitors. And there's data that's come out now in the last year, and I can't remember if we reviewed it here last year or we've talked about it a couple times, that even with this additional LDL lowering, they have shown benefits to patients in terms of mortality and lower infarcts. So now we're pushing we're pushing it even lower, and the question is which patient gets pushed to what point. So even if you're some patients actually go to 1.0 or 1.2 or 1.3 with a statin by itself. It does happen, but which patients whose LDL is 1.8 should we be pushing even lower if they have coronary disease? And I'm not sure yet, but there is data now that the addition of these new drugs on top of the statins in that patient's care does have benefit. And they're expensive drugs. It's a little bit complicated. We're trying to work our way through it. But Claudia, anything you want to add about that?
I think that, with respect to your situation, if you're tolerating the atorvastatin 80 milligrams, I think it's a great alternative for you. Yeah, I think that, nothing to lose, lots to gain. That class of medications has shown real benefit in terms of reducing the risk of important things like myocardial infarction and death. And now this new drug class, the PCSK9 inhibitors, which may be something you're on in the future, have shown even further benefit on top of statins.
I have a guy here called, Dr. Sheldon Cole.
Yes.
After my surgery, when I was at a research, now that pill they had, Jarvis, they took me off on Shining Deck, in Bocana, and put me on, Dr. Gupta is my cardiologist, and they put me on Jarvis from 10, then they put it to 25 milligrams.
Yeah.
I think it comes with 10 and 25.
That's right, yeah.
Yeah.
So the doctor, I'm told, after his research, he told me, okay, still on that. Now we cut off, I was at 20 milligram Altis, Ramatrel, right? Now he cut it down to 5 milligrams.
Yeah.
Because after this, again, the surgery, my blood pressure is 110 over 60, 110 over 70, 170 over, once it went high, 120 over 80. I said, Dr. Jamal, what is that? What was that? You know what the man told me? He says better than this, 120 over 80.
So, I think what you bring up, and maybe just so the audience outside here can hear, is how do you adjust all of these medications that we know are efficacious and actually improve mortality when there are several different classes are being used together and patients have their unique circumstances, someone who's finishing surgery, someone whose blood pressure is low, and that's really the art of medicine. I think we all realize what the targets should be. Not every patient can get to that target because the side effects of the drug may limit that. And it's not always possible to take the maximum dose of the drug that we would like to. At least sometimes you have to work at it. But it's important to be on those medications, and then the art of medicine becomes adjusting the dose that the patient can live with it, and you get the maximum benefit because the studies are always done at a certain level of the drug. And if you haven't reached that drug dose, then you're not sure if you get the full benefit of it. Anything you want to add to that at all, Claudia? Or?
No, I agree, yeah.
So thanks for your question. Okay.
No rapid sliding scale.
Yeah.
On the Victoria, I started 0.6, 1.2, and then now I'm 1.8. You know what it is, right?
Yep.
So maybe.
And then placebo 1
You can see that it's a very complicated medical regimen that you're on, and it just highlights what we're saying.
Looking after me, I think I'm a guinea pig.
No, I don't think you're getting it. And other questions that we have from the, yes, please, yes.
How do you help the test, the insulin with the new medication?
So how do you adjust the insulin dosing when you're on it with these new medications?
I have been diabetic for 25 years and I'm taking urea and the metformin with my blood sugar high. So I took the Lantus instead of
Right. So your insulin requirements are generally they're lower if you're started on one of these new agents. Yeah.
better, the medication would have been better than the Lantus?
Better, not necessarily. If you require insulin, then you require insulin, but they can adjust your insulin requirements if you're on the combination.
Either I take the Lantus or I take the Vaca.
Yeah, so just so those listening in, the question is, what do you do with insulin when you go on these new medications? And it's, once again, you have to probably adjust the dose of insulin because otherwise your blood sugar will go too low. Any other question? No. Okay, with that, I ask you again if you can fill out the evaluation forms when you leave, because we always find that helpful when we're planning the program. And I want to thank our speakers for this evening, and thank everyone for their patience in staying here till this time on a very difficult day. And to the audience out on webcast land, we wish everyone a good night and safe trip home. Thanks very much.
Thank you.